For the next session, I'd like to call upon Dr. A. Ganeshan, Senior General Surgeon of Kowe Medical Center Hospital, Dr. Professor Anuradha Chandramohan, Professor of Christian Medical College, Vellore, and Dr. Priya Ghosh, Consultant Radiologist from Tata Medical Center, Kolkata. Let's give a big round of applause for our chairpersons, please. I'm very happy to introduce our esteemed speaker, Dr. Avinash Kamarakone, Division Chief, Abdominal Radiology, Director, Center of Research, Innovation and Abdominal Imaging in Brigham's Women's Hospital. Thank you, sir. Over to you.
Thank you so much. Good morning, everyone. It's such a pleasure to be here, and I would like to thank the organizers for the invitation and opportunity. So I'm going to speak about OCUM trial. So these are the disclosures. And before I start, I want to acknowledge the contribution of my multidisciplinary team, my oncologists I work with, and also my mentor, Mukesh Harisinghani, who's helped with some of the material for this talk. So what I plan to do in the next 20 minutes is discuss the treatment paradigm in rectal cancer, then go over the salient aspect of the OCUM trial, and then review the imaging perspective in OCUM trial. So to start with, this is an example of a patient. You're seeing a patient with a rectal cancer, had a liver metastasis, highlights the importance of early detection in colorectal cancer. This is the third most common cancer and the second most common cause of cancer mortality worldwide. Just in 2020, nearly 2 million new colorectal cancer cases and nearly 1 million deaths were estimated due to colorectal cancer. The incidence is steadily rising in developing countries while it's declining in the US. Surgery is the main treatment option. However, neoadjuvant and systemic treatment options are available in more advanced cases. Now, if you look at the staging perspective in patients with colon and rectal cancer, you can see how the 5-year survival rate reduces as the stage increases. Now, even though the colorectal cancers are clubbed together, the treatment paradigm in colorectal cancers are different. For example, in colon cancer, the primary treatment option is surgical resection of the tumor along with adjacent mesentery and the lymph nodes. The need for adjuvant treatment is decided based on lymphovascular invasion or presence of positive nodes at surgery. However, in rectal cancer, the management paradigm is different based on the local extent of disease. So why is rectal cancer different from colon cancer? That's because the treatment in rectal cancer before surgical resection depends on level of tumor invasion across the rectal wall and also on the depth of extramural and local spread. It has been shown that in patients with locally advanced rectal cancer, there's higher local failure rates. Also, given the location of rectal cancer in the pelvis, lack of serosal layer, and the complex anatomy makes surgical resection in the pelvis extremely hard. So these are hard surgical operations for colorectal surgeons. Now, not all rectal cancers are the same. So if you look at these ESMO clinical practice guidelines, you can see in the TNM risk category for rectal cancer, categorizes rectal cancer on very early, intermediate, locally advanced, or advanced rectal cancers. If you look at the treatment paradigm, this is a complex slide. It just shows the heterogeneity and the different treatment options available for management of patients with rectal cancer. Again, the management paradigm rectal cancer is complex because not all rectal cancers are same. We looked at the risk stratification based on local staging. The location of the tumor dictates local recurrence, and also more recently, the MSI and MSS status of the rectal cancers also determines treatment options. Now, not all goals of therapy in rectal cancers are the same. For example, treatment option depends on the quality of life, such as bowel function, fertility, and sexual health, and also the need for sphincter preservation. So there is increasing move towards personalizing rectal cancer therapy in this era of precision medicine. Now, if you want to simplify the management of rectal cancer, early rectal cancer, that is T1 and T2 tumors without nodal involvement or vascular invasion, or often undergo upfront surgical resection, that is total mesorectal excision, while those patients with higher stages of rectal cancer, T3, T4 disease, or node-positive disease, or those with vascular invasion, often undergo some sort of neoadjuvant treatment prior to mesorectal excision. Highlighting here that the pelvic MRI plays an important role in local staging of rectal cancer. Now, what about neoadjuvant treatment? There are several different types of neoadjuvant treatment options available in rectal cancer. Let's see, the goal of these neoadjuvant treatments is to enable complete resection when total mesorectal excision alone is ineffective in later rectal cancer. So preoperative radiation therapy improves R0 resection rate, improves local control, and also provides an option for organ preservation due to improved TME-free survival. Preoperative chemotherapy improves systemic control, improves response and organ preservation, and also there's more recent data which suggests that total neoadjuvant therapy can affect micrometastasis and reduce the risk of distant metastasis. So let's quickly look what total mesorectal excision is. Total mesorectal excision refers to complete resection of the rectal cancer and the surrounding mesorectum, either through an LAR or an APR, and it's characterized by dissection by the surgeon along the mesorectal fascia. Now, the contents of resection in total mesorectal excision include the tumor, mesorectal fat, lymph nodes, and tumor deposits. Now, the goal in total mesorectal excision is to attain a negative circumferential resection margin to reduce the risk of locoregional recurrence and also increase the chance of cure. Now, there are two terms here which I want to highlight and discuss a little more in detail, the mesorectal fascia and the circumferential resection margin. These are not equivalent. While mesorectal fascia is an anatomic plane, which is a fixed, thin structure which envelopes the rectum, mesorectal fat, the nodes, and the lymphovascular supply, while circumferential resection margin is a surgical plane. It's the potential surgical dissection plane along the non-peritonealized surface of the rectum. So it may or may not follow the mesorectal mesorectal fascia. So if you look at the mesorectal fascia, this demarcated on the green line here, we can see the mesorectal fascia envelopes the rectum completely in the mid and lower portion. And as you see the anterior peritoneal reflection extends into the upper and mid rectum, the mesorectal fascia is seen only on the posterior and lateral aspects. Understanding this anatomical description is important when you report involvement of mesorectal fascia on pelvic MRI. Now, mesorectal fascia involvement needs to be described only for T3 tumors, not for T1 or T2 tumors. In low rectal tumors involving the anal canal, mesorectal fascial involvement has to be described only for the rectal component. And mesorectal fascial involvement is best depicted at the base of the tumor. Now, when you have to determine positivity or involvement of the mesorectal fascia, you need to look at the minimum distance between the most penetrating aspect of the tumor to the mesorectal fascia, EMVI, or the spiculated lymph node. So if you look at these images here, the first image on your left shows a primary tumor involving the mesorectal fascia. Second image demonstrates a spiculated nodule, which is sitting on the mesorectal fascia. And the third image demonstrates a EMVI, which is close to the mesorectal fascia. Involvement of the mesorectal fascia is a strong predictor of circumferential resection margin positivity and therefore a predictor of local recurrence and poor survival. Now, if you look at this data, which looked at circumferential resection margin involvement and local recurrence, you can see at 5 years, 90% of the patients with negative margins had no local failure, while only 22% of patients who had negative margins, who had circumferential resection margin involvement had no local failure. So it demonstrates how having a negative circumferential resection margin has such an important impact on local recurrence. Now, given the benefit of having a negative margin resection, there have been several clinical trials in rectal cancer looking at various different total neoadjuvant or neoadjuvant chemoradiation therapies in management of patients with advanced rectal cancer. And for this talk, I'm going to focus mostly on the OCUM trial. Now, one of the prerequisites of rectal cancer management in all these trials are four. One is high-quality MR technique and interpretation, excellent surgical technique, standardized assessment of pathological specimen, and multidisciplinary review of all cases prior to treatment. So let's see what this OCUM trial was. Now, this OCUM trial, I'm not going to butcher the French, I think it's French terminology for the OCUM trial, but it actually referred to optimized surgery and MRI-based multimodal therapy in rectal carcinoma. So the rationale for the OCUM trial was that most guidelines recommend neoadjuvant radiotherapy or chemoradiotherapy for patients with stage 2 or stage 3 disease without considering risk factors for local recurrence after total mesorectal excision. Now, one of the most important risk factor for local recurrence after TME has been shown to be pathological CRM, followed by T staging, and lymph node status has not been shown to influence the local recurrence risk. And also, rectal MRI, despite high quality and technique, has certain limitations in staging the T stage and the nodal stage. So if you look at nodal staging, there was this study which looked at a 10-year period of nodal staging, and they found that the nodal staging on clinical stage increased from 70 to 53% over a 10-year period, while the pathological nodal staging remained stable at 33%. What it highlights is there is a lot of overstaging of nodal stage on the MRs over a 10-year period. Also, if you look at T staging, the accuracy of MRI in T staging is around 64%, with overstaging in nearly 23% of patients. And also, if you look at high volume centers, the accuracy is not really different from low volume centers. That is 67 versus 62%. So there is high risk of over-treatment and under-treatment when you use nodal staging or T staging for determining neoadjuvant treatment. And also, given the adverse events of neoadjuvant therapy, which can exacerbate negative consequences of surgery, there is a push to personalize neoadjuvant treatment option in those patients who are high risk for local recurrence. So one of the key objectives of the OCUM trial was, so can patients with a tumor-free mesorectal fascial involvement on pelvic MRI be omitted from neoadjuvant chemoradiation and be cured by upfront total mesorectal excision? So that means you're risk optimizing patients for neoadjuvant chemoradiation based on MR depiction of mesorectal fascial involvement. So the hypothesis was that the pelvic MRI can predict tumor-free circumferential resection margin involvement with high accuracy and therefore high quality TME, total mesorectal excision. So the pelvic MRI should be able to distinguish two types of patients: those low-risk patients, those who do not have involvement of the mesorectal fascia, and high-risk patients who have involvement of the mesorectal fascia. So the low-risk patients who do not have involvement of the mesorectal fascia would undergo upfront total mesorectal excision, while those patients who have involvement of the mesorectal fascia would undergo preoperative neoadjuvant chemoradiotherapy prior to mesorectal excision. So this OCUM study was a multi-center interventional study which recruited 1,099 patients from 2007 to 2016. The inclusion criteria was solitary rectal cancer, that is within 16 centimeter from the anal verge. They include all stages from T2 to T4, any nodal stage, and without distant metastasis. The intent in these patients was elective surgery with curative intent. The primary endpoint in this study was a 5-year local recurrence rate less than 10%. And there are several secondary endpoints, including a percentage of involvement of the circumferential resection margin, the quality of mesorectal excision, the overall survival and the disease-free survival rate, the frequency of distant metastasis, and need for neoadjuvant chemoradiation, and also the adverse events in these patients. All the patients in the study underwent high-resolution pelvic MR. The minimum distance of the tumor from the mesorectal fascia was measured. Those patients who had minimum distance of less than a millimeter were considered positive for mesorectal fascial involvement. Those who had a distance of more than a millimeter were considered negative for mesorectal fascial involvement. Lymph node metastasis was determined based on certain morphological criteria. So they had basically categorized patients into two groups, a low-risk group and a high-risk group. High-risk group were those who had negative mesorectal fascial involvement, and they had tumors in the mid or the lower thirds, and all upper third tumors from 12 to 16 centimeter. High-risk group included those patients who had positive mesorectal fascial involvement for mid and lower third tumors. They included all T4 tumors, mid, upper, and lower third in the high-risk group, and also those patients who had lower third rectal cancers, even if they had no involvement of the mesorectal fascia, were grouped into the high-risk group because of difficulty in predicting the mesorectal fascial involvement for lower rectal tumors, and also because of the poor prognosis in these group of patients. So the low-risk group of patients underwent total mesorectal excision on upfront, while the high-risk group of patients underwent preoperative chemoradiation prior to a surgical resection. I want to briefly go over how they determined the location. This is how determination was done based on mid, lower, or upper rectal tumors based on the distance from the anal verge. T staging was done on the Mercury trial, where tumors were divided into T1, T2, T3, T4, or T4B. I won't go into details on this. The treatment plan, all the patients who were in the high-risk group received neoadjuvant chemoradiation, which included long course radiation over 5 weeks. They all got 5-FU-based concurrent chemotherapy, and surgery was performed 6 to 8 weeks after completion of neoadjuvant chemoradiation. A follow-up was done 6 monthly in the first 2 years, and annually for at least 7 years. Treatment efficacy was looked on based on tumor regression on pathology, downstaging after neoadjuvant chemoradiation, quality of mesorectal excision, the local recurrence rate, and the distant metastasis rate. This image here shows the recruitment and the flow chart for the patients in this trial. You can see that 530 patients underwent primary surgery, while neoadjuvant chemoradiation was administered in 354 patients. 60% of patients, as I showed, underwent upfront surgery, 40% underwent neoadjuvant chemoradiation followed by surgery. Adjuvant treatment was required in 35% of patients in the low-risk group and 77% of patients in high-risk group. Complete response was seen in 12% of patients. This is a busy slide, but you can see here that R0 resection was achieved between 97 to 99% of patients in both the cohorts. And if you look at the negative mesorectal involvement, circumferential resection margin, you can see the rates was between 91 to 98%. Now going over the local recurrence distant metastasis, the local recurrence rate was 2.9% in the upfront surgical group, while it was 5.7% in the patients who underwent neoadjuvant chemoradiation. The distant metastasis, overall survival, and the disease-free survival were all lower in the patients who underwent upfront surgery. This is just the Kaplan-Meier curves in this cohort, demonstrating those patients who underwent upfront surgery performed better than those who had neoadjuvant chemoradiation. Now, as I mentioned, the disease-free survival and overall survival was significantly better in the lower risk group, and the independent risk factors for distant metastasis were found to be 3T and T4 tumors and involvement of the mesorectal fascia. Now, there was protocol deviations in 215 patients. That is, 104 patients were called the under treatment group, that is the high-risk group, who did not receive neoadjuvant chemoradiation due to old age, comorbidities, or refusal to undergo treatment. And in 111 patients, there was overtreatment. That is, those with low-risk tumors decided to undergo neoadjuvant chemoradiation, either because they wanted to have sphincter-saving procedures or desired to do watch-and-wait protocol. And if you look at the local recurrence rate in the undertreated group, it was 10.1% versus those who had overtreatment. The patients who were overtreated were mostly younger, who had tumors in the lower third, and had more clinical stage 3 tumors. So the salient conclusions of this study was that neoadjuvant chemoradiation in low-risk patients provides no advantage over optimized surgery if a 5-year local recurrence rate of approximately 5% is acceptable. So neoadjuvant chemoradiation and its adverse events can be avoided in 60% of total population and 45% of patients with clinical stage 2 or 3 cancer. High-risk group, that is those who have involvement of mesorectal fascia, have higher rates of local recurrence, systemic metastasis, and unfavorable overall survival and disease-free survival. There were certain limitations to this study. This was not a randomized study. There was high percentage of protocol deviation, and also the growing interest in watch-and-wait strategies led to increased over-treatment decisions. So I want to briefly go over a study which came out of this OCUM trial, which particularly looked at role of MRI. Now here I want to discuss a little bit on the participating sites. There were 14 participating sites in the OCUM trial. There were high volume, medium volume, and low volume sites, and there were more low volume sites than high or medium volume sites. If you look at the MR protocoling and reporting, it was all standardized. Each site had a GI radiologist who was responsible for interpreting the images, and all images were discussed at multidisciplinary tumor board. And all these patients who were reviewed on the MRI were those who had undergone upfront surgery, that was treatment-naive patients. If you look at the accuracy of T staging, which was found in this group, it was that this T staging was accurate in 63% of patients, with overstaging in 22.9% and understaging in 13% of patients. And if you look at the accuracy of staging, it's interesting, the low volume and the high volume centers, though they were statistically different, they were not too much of a difference from 62 to 67%. Interestingly, those with the median volume group had lower accuracy of staging. The accuracy of staging was better for T3 tumors versus T2 or T4 tumors. And if you look at nodal involvement, the MR accuracy for lymph nodal involvement was 57%, with no significant difference between participating centers, and the specificity for predicting absence of nodal involvement was 53%. If you look at accuracy for pathological staging, there was overstaging in 34 and understaging in 18% of patients. Looking at the ability of MRF to predict a circumferential resection margin, it had a high negative predictive value of 98% without significant difference between the participating centers. There were certain limitations that the variability in the radiologists, and the focus of the study was for MRF status and not nodal and T staging, so that could have led to selection bias. So they concluded that MR prediction of tumor-free margin is more reliable than prediction of tumor stage, so MRF status as determined by MRI should therefore be prioritized for decision making. So the time is 2 seconds and I'm done, so thank you for your kind attention.
Excellent presentation. Very good summary of the rectal cancer. You're a radiologist, right?
Yes.
You're talking very well about the surgical treatment and everything. Any questions from the audience? Okay, I think it is beyond doubt as proven so far. At the moment, MRI is the gold standard for the rectal cancer staging. And the treatment part is the resection of the tumor completely without CRM positivity. Okay, so if the CRM is threatened, we are going to go for a local treatment. This paper is excellent in the saying that the surgeons, we want to do upfront surgery because we don't want to go into the rectum which has been already irradiated and chemotherapies, especially after a TNT. The surgical risk is more. This paper addresses what I always tell, upper third tumors, we can always go ahead even without a preoperative therapy. The one thing this paper has not addressed is the robotic surgery. Because the trend nowadays is most of the rectal cancers in higher centers in Western countries are treated by robotically. And the trend is CRM positivity is less when you go on a robotic platform. Because if your CRM is positive after surgery, the tumor cells are present at the resection margin, invariably he will get a recurrence. Okay.
Hi, Avinash. I just want to make one comment. One of the major limitations I thought in the study is they haven't disclosed the pelvic sidewall disease status. And that is one of the major determinant in deciding chemoradiotherapy, because oftentimes it's very difficult to address the lateral pelvic sidewall disease with upfront surgery. And that is one of the major determinant of local recurrence as well. And also this does not very robustly touch upon the differences between tumor deposit and EMVI, which are tumor deposit and lymph node difference, because these are newer concepts which came much after the trial started. So those are two things to keep in mind when we interpret the study. And for us, I think for radiologists, it's important to keep in mind the difference between lymph nodes and tumor deposits. And missing lymph nodes is not a big deal, because nodes repeatedly, multiple studies have shown that it does not correlate with survival at all. But whereas tumor deposits definitely correlates with disease-free and overall survival. So, and that determination at the moment is in the hands of radiologists, and pathologists will not be able to tell us that accurately. So I just want to leave us with those comments. Thank you very much.
Thank you. No, I totally agree. Actually, yesterday I showed a case during my workshop where a patient, exactly what you said at the first point, who had T1, T2 disease but had a lateral pelvic lymph node which was not identified initially, which led to local recurrence.
Absolutely.
Absolutely. Thank you.
Thanks for the wonderful talk, but I just had one question, sir. So, in the present era of total neoadjuvant therapy, how is this trial relevant now? So.
Pardon?
This trial did not consider TNT regimens, right? This was older than the present regimen. So
Exactly.
how is it relevant in the present practice?
So, I think one of the things which I showed is that total neoadjuvant therapy more and more is showing that it can help identify help treat micrometastasis, which can reduce the distant metastasis rate. One of the challenges I think in rectal cancer management is as much as is local recurrence is also distant metastasis. So at least at MGH, what I've seen is there is a lot of push to do total neoadjuvant therapy, even if there are certain high-risk features or lymph node positivity. And plus, again, you want to understand that patients today are so informed. So this is always a discussion with the patient as to what their options are. If you see in this trial, there was so much of protocol deviation, exactly to your point, that more patients wanted over-treatment and wait and watch. So I think personalization is what is key, but it also highlights the importance of imaging and looking at features which help you identify high-risk features prior to a patient undergoing treatment or risk stratification. But absolutely, total neoadjuvant therapy has changed some of the paradigms in management.
Still, the
Yeah, no, I know, but a lot of our medical and radiation oncologists don't think much about Rapido trial because they had higher local failure rate, in the Rapido trial. So that's why, usually, of course, if you talk to radiation oncologists, they will go on length. They'll talk about for 2 hours on short course versus long course radiation treatment. But yeah, maybe it does address, but I think that at least what I've seen in our practice is not a lot of oncologists want to do the short course or the Rapido trial, paradigm for rectal cancer patients.
we in our center, and I think most of the centers, TNT is offered in selective group of patients only for high-risk patients and the patients whom we are going to give a permanent colostomy, like AP resection. Other patients will still go for a conventional either long course or short course radiotherapy. And in one caveat is that low rectal tumors, like very, very low, when almost the mesorectum is away. After 5 centimeters, there is no mesorectum. In that areas, even T2 tumors, we give them radiation, at least a short course radiation.
Thank you, Dr. Avinash. With that, we'll close this session. Thank you very much.
Thank you.
Thank you, chairpersons, and thank you, Dr. Avinash, for the in-depth talk.